by the people, for the people, the gathering to get healthcare now. Chapter 19, reporting healthcare encounters. Reporting healthcare encounters might seem to infringe on patients' liberty. However, there are others who regard such cooperation as necessary to proper treatment of patients. For example, such detailed record keeping enabled Dr. Paul Farmer in Haiti to relieve the suffering of others. The run-of-the-mill practice of encounter reporting required to be paid by the insurance company can be corrupting. A doctor cannot codify diagnosis and treatments without reducing the information discovered, even if the ICD-10 codes are used. Further, reports made based on payment can be tainted by greed or sloth. In some, records can be unwittingly corrupted, and the greater the number of these reports, the more corrupt the collection becomes. A simple test is to ask a doctor who needs to see the medical records of a patient if the encounter reports submitted to the insurance company for claims will do. He or she will most likely just laugh at the question. Disconnect compensation from reporting, as in Dr. Farmer's case, and you could get valuable information to an epidemiologist. That's exactly what must be done in an IPA. Real medical records recorded in a real medical record system. While codification makes the record easier to sort and compare, does not improve it. Since most of the new electronic medical records and billing systems enable the physician to know exactly which diagnosis and procedure codes will be paid by the insurers at the highest rates, the physician can use a pick list to improve presentation of the patient's problems and the coded services. Such a system tends to corruption. There are thousands of medical record systems, and so far, only hospitals and large group practices have been able to make sharing and maintenance of records somewhat useful and practical. This move forward has been very slow and done at great expense. It is unlikely that IPAs, unless rebuilt on a group practice model, will be able to harness the beast. Nevertheless, they should make the attempt. Lately, there's been a push to open source systems that include OpenEMR and LibreEMR. OpenEMR is a robust system that was certified in 2011 and again in 2015. It is free only in the sense that a person does not pay a proprietary license fee to use it. However, you must learn it, and most of us must pay someone to install, support, and train other people to use it. The hope of the thousands of doctors and geeks who use such a system is that it will become a standard, like Linux. If it does, then our physicians in the IPA might be well served. Because the record-keeping side of medicine is understood and managed dynamically, it's difficult to convert people to a wholly computerized system. Our physician organizations have had that computerized record-keeping system since the late 1960s, and the only thing that has lasted over that 50-year period has been the printed copies of the records, and not even all of them. At the level of operation of a physician's office, the maintenance and storage of medical records electronically is very risky. Natural catastrophes happen frequently, and they do damage to machine support systems. Just being without electricity for a week suspends these systems, and you're left with hand-recorded paper records. Even the NSA is not able to keep its system up all the time. The saving grace in medicine is that the human body is a record of its health, and a physician can recreate a copy of that record for a patient by physical examination and questioning. Sometimes what has been recorded in the past is not so helpful and not as important as people think. It's not the medical record per se that drives the perceived need for automation. It's the third-party payer system that drives it. There are no physicians or patients who would not survive a complete meltdown of the electronic records, medical or claims. But there are no insurers that can make cost predictions and policy determinations without a claims database supported by medical records. This would be true even if the data collected were not true, which is the case in all the current claims databases, and the records were either upcoded or downcoded. Corrupt or not, it's tied to the money and the budget and the policies. So for the sake of the insurers, they think it must not melt down. A reformed healthcare system would dump all the past histories from those corrupted databases and start clean and not connect the medical records to payments. A strong desire to see this and to see the world as it is should keep the IPA and its members from becoming delusional and following the instinctual path of regarding encounter reporting as a bit of a joke. Some physicians have picked a few codes and a few basic charges, and that's all they report. And to them, it's an uncomplicated way to report claims and get paid. About 10 years ago, Medicare decided to pay the health plans based on the morbidity of their patients. To establish morbidity, one must report all the diagnoses and procedures done and reestablish the diagnosis every year. At first, it seemed that CMS had a perverse sense of humor. It must have known that a large percentage of the physicians would not go to so much trouble in reporting their claims to the health plans and other insurers. I assume someone thought the reimbursements would fall because of lack of reporting. Eventually, the joke was on CMS because the health plans and the physicians went to school about this, and the reporting became more robust than the real lives of their patients. As mentioned in an earlier example, physicians will buy computer software that makes upcoding much easier and harder to detect. It took about a year for that to happen in our community. HCC coding raised the profits about 30% for the dominant health plans. There may be a point in time when medical records are recorded perfectly and stored electronically to be shared quickly with all the providers needed to attend to patients. However, providers must be able to report exactly what is discovered in the encounter with the patients. There can be no understatement or overstatement. It must be done in a timely manner and through the channels available for those communications. Using EMRs and electronic claims transmissions will make it easier to report the findings. We think advanced payment is a better system. However, payments based on posting of medical records and codification of services is too complex to be practical. A better payment method for medical and surgical care is to pay in advance of the care and treatment. The worst way to pay is by claims, which are made based on assignment of benefits to providers from patients to their insurers. And that's not to say that insurance is not useful to a patient. But like other kinds of insurance, it works best as a reimbursement or indemnity claimed by the patient after the patient has proven the cost of the claim. The reason it cannot be used as currency is because the contracts between the insurer and the patients vary greatly, and there's no way for the service provider to determine the value of any policy in cases at any given time. If the payment in advance took the form of a retainer agreement between the patient and his or her medical care provider, then the cost of providing the care would drop dramatically and the complexity of the financial transactions would be eliminated. The notion that insurance is a prerequisite to getting and paying for health care is horse manure. The only reason that people hold such opinions about the relationship between insurance and access to health care is that they have not examined the nature of the financial transactions involved. First, consider what's been done in setting prices for health care. We can use Medicare as an example, even though the resource-based relative value system they use to determine prices has been adopted universally, with only a variation in fees, lower and higher. The core problem with the RBRVS is that the fee schedules generated from it are expressed in over 20,000 codes, which makes it impossible for a patient to know how much his or her medical or surgical care will cost. It is as if you went to a restaurant and they had no prices on the menu, and the menu was 3 inches thick, and you would not be able to settle your bill until it was examined by an outside accounting firm sometime in the next 120 days. Further, without you knowing it, the final bill for the meal included food delivery charges, a portion of the electric bill for the restaurant, and the waste management company's separation and safe disposal of your leftovers and napkins. Now, if you're not screaming yet, it's because you've not really been sick or hurt and had to deal with the current system. All patients want is care and treatment, and to know what it will cost and when to pay for it. All doctors want is to take care of patients and be paid for it. So here's the proper answer. Simplify the pricing so that the transactions can be closed before the services are rendered. It's a piece of cake. We know what doctors and hospitals earn now from patients they have been seeing. Oddly, there's very little variation between similar practice in the revenue they produce and the number of patient encounters and procedures they do. As an example, primary care practices produce between $400,000 and $600,000 in annual collected income from all sources. If the PCP sees a patient every 20 minutes for 8 hours a day for 240 days a year, he or she would have about 6,000 encounters and serve a population of 1,500 patients. The current average collected fee per encounter is $85. If 200 of the encounters are procedures and 5,800 are exams, then the gross revenue of $540,000 would result from $493 in collected revenues and $47,000 in procedures. Each procedure would then average $235. So the PCP could charge patients $85 for the encounter and $235 for the procedure. They could go a step further and make a retainer agreement to pay the doctor $30 a month and not even worry about billing. Do the math. 30 times 1,500 times 12 equals $540,000, the amount the doctor expected to earn and the amount the patient knew had to be paid. Suddenly you realize that many people are removed from the claims verification and processing services and from the nightmare of insurance reconciliation accounting. The practice will find that overhead drops $100,000. This system of price setting for services and direct collection from patients is applicable to surgical and diagnostic specialties as well as it is for PCPs. Most surgeons have about 400 procedures per year and 3,600 encounters, and if their exams average $85 and their procedures would average $1,072 for gross income of $700,000, that's the level of income for most surgeons. They could have a two-price system and advance payment too. This system does not stop the patients from using insurance for reimbursement, but the practices must give the patients a standard claim form to file for their reimbursements. Production of this would be a minor expense and a byproduct of maintaining the medical records. Yeah. Well, what about the poor? What about the poor? They need money. Their friends and family, the community, and the government must give it to them. It's called moral responsibility. We should not make giving money to the poor to pay for health care into a maze followed by a gauntlet. Neither should we say that we must be assured the poor are deserving of help beyond the fact of their poverty. As family, friends, and community and government, we cannot de facto require charity of only one segment of our society. Ask not for whom the bells toll. It tolls for thee.